Hello, everyone, and welcome to today's workshop. My name is Daheen Gustav, and I will be providing technical assistance during the workshop. Closed captioning and ASL interpreting are being provided. To view the interpreter, set your screen to gallery view. You can switch between gallery and speaker view in the upper right-hand corner of your screen. To view the captioning, click on the CC icon at the bottom of your screen and select Subtitles. All attendee microphones have been muted to avoid background noise and webcams turned off to allow attendees to easily view the interpreters. During the Q&A session, please use the chat box to ask a question. Your question will be read out loud by the session moderator for the presenter to answer. This workshop is being recorded and the recording will be made available for future viewing. It is now my pleasure to turn it over to Dr. Amanda Ricard, Program Specialist at the National Institute on Disability, Independent Living, and Rehabilitation Research. Please go ahead.
Thank you. Hello, and welcome to day 3 of the Accessibility of Motherhood, a workshop on disability and pregnancy. And I just realized I pulled up my notes from day 2, so I'm going to move over to day 3. So as Daheen said, my name is Amanda Ricard, and I'm a project officer at NIDLR. And I'm so grateful that you're here joining us today. This is such an important yet underreported and overlooked topic. And I just want to thank you for taking the time to be here, whether it's your first day, your second day, or your third day with the workshop. We're really glad you're here. Your attendance really shows that your enthusiasm and your devotion to helping ensure that women with disabilities can have healthy pregnancies and healthy pregnancy experiences that are respectful and appropriate and accessible. So on behalf of NIDLR and NICHD, welcome and thank you for being here. Before I begin, as with the other days, I must thank all of the tremendous colleagues at NIDLR and NICHD and New Additions that made so many invaluable contributions to make this event possible and for making the workshop run so smoothly this week. I'm most grateful for all of them, all involved in this team effort, so thank you very much. We hadn't talked as much about, it's kind of come up in pieces, but I wanted to point out that this workshop is only one piece in a series of work that NIDLR and NICHD have been doing regarding reproductive health of women with disabilities, women and adolescents, I should say. We started in the winter with a brief on disability and pregnancy, which summarized the research from NIDLR that was funded by NIDLR and NICHD regarding disability and pregnancy and actually more broadly reproductive health. Then last week, NICHD held a webinar entitled Reproductive Health Care for Persons with Disabilities Across the Transition from Adolescence to Adulthood. And that was fantastic and well attended. And then before that, we offered a disability and rehabilitation research program as a funding opportunity for disability and pregnancy this year at NIDLR. And we held that competition earlier, and one of our panelists, Monica Mitra, is the person, the PI for the grant that was the winning submission. So it's exciting to have Monica as part of our panel in addition to being the PI on that project. And it's NIDLR's first funding announcement that included pregnancy that was on this specific topic area. So it's pretty exciting to see that highlighted. And then this workshop is the most recent piece, and we'll at least be writing a report from this or summary from these past 3 days. And we absolutely hope to continue to move this forward since this topic has so many gaps in the research and policy, and the work is really critically needed. So I hope you were able to join us in the past couple of days, but if you weren't, that's okay. I wanted to do like we did yesterday and just take a moment to catch you up to speed by asking those who were able to attend to tell us in the chat box what your biggest takeaways were from yesterday's session with the healthcare providers. So if you will, type in the chat box any points the healthcare providers raised that left you left the workshop thinking about most. And while you're doing that, while we wait for those to come in, I will just remind you that the goal of this 3-day interactive workshop is to identify priority areas of focus and create momentum for the research agenda needed to address inequities in pregnancy outcomes and related healthcare among women with disabilities, especially the inequities experienced by those from underserved and underrepresented populations. So I'll give it another minute for you to encapsulate, some highlights of yesterday's incredible engagement and type it into the chat box so we can share the experience and powerful moments with everyone here. Well, no one's sending it. Oh, wait, there's one. Ami says the urgent need to foster more capable students from the various disability populations into higher education fields so that they can become credentialed providers of the services we need for concordance with patient populations. Yes, that definitely came up at both days, I think. From Jackie, such a tremendous need for training of providers and health systems to provide respectful, appropriate care to pregnant people with disabilities. From Patrice, what can I do to make a difference? So Patrice, I hopefully will have some answers to that today, and I think that's a really good topic for us to include in our summary. That will come out of this, some suggestions for what people can do to make a difference. I appreciate you asking that question. All right. So if while we wait for some others to come in, if they do, I will go ahead and introduce our wonderful panel today. I mentioned Monica Mitra. She wears many hats, as all of our panel members do. She is an associate professor at the Nancy Lurie Marks Nancy Lurie Marks Center of Disability Policy at Brandeis, and she's the director of the Lurie Institute for Disability Policy. She's also the co-PI of the recently launched Center for Disability and Pregnancy Research, as I mentioned. And she's the co-editor-in-chief of the Disability and Health Journal. And that's a very brief list of her many, many roles. Hilary Brown, Dr. Hilary Brown is an assistant professor at the University of Toronto in the Department of Health and Society at the Dalla Lana School of Public Health and an adjunct scientist at Women's College Hospital and the Institute for Clinical Evaluative Sciences. She holds a Canada Research Chair in Disability and Reproductive Health, and her research program, which is funded by the NIH and the Canadian Institutes for Health Research, uses epidemiologic methods to examine maternal and child health across the life course. And she has a particular focus on populations with disabilities and chronic illness. And last but not least, we have Dr. Eric Rubenstein. He is an assistant professor of epidemiology at Boston University School of Public Health. He focuses his work on improving the lives of individuals with intellectual and developmental disabilities, or IDD, including Down syndrome and autism spectrum disorder. He currently is the PI of an NICHD funded study of pregnancy in women with IDD and a National Institute on Aging funded study of health outcomes for Medicaid enrolled adults with Down syndrome. I know we had a couple of people over the past couple of days asking about information regarding women with IDD specifically. So I think this panel, hopefully those people are on today and they can ask their questions and learn from the panel members today. And with that, I will turn it over to Dr. Mitra as the moderator.
Great. Thank you, Dr. Riekert, for the kind introduction, and good afternoon to everyone and welcome. As Dr. Riekert mentioned, I am Monica Mitra and I direct the Lurie Institute for Disability Policy at Brandeis University. I'm a brown woman with shoulder length black hair and I'm wearing an orange blazer over a black top. I am truly delighted and honored to moderate today's session on the accessibility of motherhood, a workshop on disability and pregnancy with two fabulous researchers, Dr. Eric Rubenstein and Dr. Hilary Brown, both of whom have made significant contributions to our understanding of the perinatal outcomes faced by people with disabilities. But before I begin, I'd like to thank the NIDLR team for organizing a workshop focused on the perinatal health of people with disabilities. This is a topic that has for too long been ignored. And as researchers, policymakers, advocates, providers, we appreciate the attention to this issue and the charge, as Dr. Alison Cernich specified on Monday, in moving the needle on pregnancy and disability research. The presenters over the last 2 days have already identified several significant and important issues that need to be addressed in order to improve the maternal and birth outcomes of people with disabilities. On the first day of the workshop, Dr. Erin Andrews, Ms. Heather Watkins, and Ms. Jennifer Sender identified the need for developing supports for disabled people during their pregnancy, the need for cultural competency and sensitivity training for healthcare providers, and identified the gap in our understanding of the range, nuance, and complexity of disability while being mindful of overlapping identities. On Tuesday, we had 3 clinicians give their insights on providing perinatal care to people with disabilities and the relevant gaps in healthcare provider education and research. Drs. Kirtzi Kirschner, Jean Aluson, and Dr. Tiffany Pankow, drawing upon their experiences and research, underscored the importance of teaching medical students how to care for people with disabilities as one mechanism for improving the perinatal experiences and outcomes of people with disabilities. And this afternoon, we will focus on the research and the convincing body of emerging evidence, starting with Dr. Eric Rubenstein's presentation on prenatal care and antenatal health outcomes for pregnant people with disabilities, which will be followed by Dr. Brown's presentation on the research on postpartum outcomes and care experiences among women with disabilities. While these presentations are going on, please send your questions and comments to Dr. Riekert. And we're going to start today's presentation with Dr. Rubenstein. So over to you, Eric.
Thank you, Dr. Mitra. Let me share my screen. All right, so thank you for the great introduction, Amanda and Dr. Mitra. My name is Eric Rubenstein. I'm an assistant professor in epidemiology at the Boston University School of Public Health. I'm a white man with short brown hair and a scraggly beard. I'm wearing a white collared button-up shirt and I'm sitting behind a black and gold world map. And I'm really excited and honored to be here today and be able to participate in this workshop. Some disclaimers right off the bat. I don't have any conflicts of interest to report. As Dr. Mitra mentioned, my work is funded by NICHD. And sort of to mirror what Dr. Alhausen said yesterday, because of the wide heterogeneity by disability, I'll use person first and identity first language interchangeably. And I also want to acknowledge that not all pregnant people are women. However, much of the literature that I'm going to talk about today centers on women. And when we talk about gaps and potential future areas for research, we'll talk more about gender diverse populations. So this slide has a GIF of the Wayne's World characters in their 90s clothing bowing and saying we're not worthy. And that is to express how great the last 2 days were, and how sort of as a researcher, I'm just kind of going to be telling you all about the published articles of the findings and lived experiences that our Monday and Tuesday presenters had. Really what they talked about was deep and meaningful and inspiring. And I'm hoping to provide some of the epidemiological and public health background to it. But really, I stress again how impactful their talks were. So why do we care about prenatal care? Prenatal care are healthcare visits to healthcare providers for a person that has an identified pregnancy from the time of pregnancy identification to childbirth or fetal loss. These visits usually include a physical exam and weight checks. And what's really crucial is they offer opportunity for moms to discuss their health and their soon-to-be child's health with their provider while asking questions. And the scientific evidence promotes prenatal care as a very important factor in health. So we know that early initiation of prenatal care, this is in the general population, is important when addressing modifiable risk factors like hypertension, smoking, and diabetes. And these factors increase the risk of maternal morbidity. And the main mechanism is through lifestyle changes and appropriate specialty care. And the sooner we can get pregnant people in and get these care plans developed, the less likely maternal morbidity is in the end. From 2011 to 2013, 1/3 of pregnancy-related deaths were among those who did not receive prenatal care or who did not initiate prenatal care until the second or third trimester. So while not entirely causal, there is a causal component here where prenatal care is associated with preventing death. So it is a good thing to do, and we should do it universally. Inadequate prenatal care is associated with stillbirth, preterm birth, postpartum depression, and lack of infant immunization, even after adjusting for other factors. So again, this is in the general population. We see really strong associations with lack of appropriate care and these outcomes. And from a sort of health system perspective, prenatal care is cost effective, and studies consistently find a positive return on investment. Personally, I'm sort of more person focused, but when we talk to legislators and policymakers, stressing the financial benefit of universal prenatal care programs and interventions to promote prenatal care as cost saving measures might sway some political audiences. So as researchers, how do we quantify prenatal care? In our data, how do we assess it? So we're going to talk about 3 ways: initiation, amount, and quality. On this slide, there's a figure, a timeline going from weeks 1 to weeks 42 of pregnancy. And it's color-coded based on the amount of visits that a person should have for prenatal care. We see that by week 4, a person should have an initial visit to look at their progress and plan a course. And then there's an expected visit once a month for the first 28 weeks of pregnancy. Then when we get to weeks 28 to 36, our visits increase to once every 2 weeks. And then in the home stretch of pregnancy, weeks 36 to 40, we would want to visit once per week. So from our research perspective, we're interested in initiation. Does the pregnant person get to their first appointment in time for the most beneficial impact? We know that earlier that they can get into prenatal care, the better we can intervene on lifestyle areas we may need to intervene or send to appropriate care. We want to make sure that pregnant people get the right amount of care. Just in pure counting sense, we have this schedule of once a month and then once every 2 weeks. We can count whether the person makes those visits as a sign of adequate care. And then it comes down to quality. In a lot of data, including claims data, we know about initiation, we know about amount, but those pure numbers don't tell us about quality. And as Dr. Andrews and Ms. Watkins and Serta talked about on Monday, there is a real lack of quality for a lot of pregnant disabled people when it comes to their healthcare experience. And we need to do a better job as researchers to figure out ways to quantifiably describe the quality of care while also using qualitative methods to really tell the stories of these pregnant people. In my work, we've adapted a conceptual model for disability-related disparities in pregnancy-related services and outcomes. This comes from work by Williams and Mohammed. It was focused on racism originally. And this is an image with 4 long rectangles. And in the leftmost rectangle, it's titled Fundamental Determinants of Health. Then going rightwards, we have social status, mechanisms, and outcomes. And here we're going from upstream factors, which are our fundamental determinants, going to downstream individual outcomes, for example, infertility. So this sort of shows the interrelationship and different ecological levels in which these disparities become poor outcomes. So for instance, in our fundamental determinants, we have societal institutions, including political and legal, economic, and cultural factors. You know, as someone mentioned, I think on Tuesday, Buck versus Bell is still on the book that allows the state governments to forcibly sterilize individuals with intellectual disability. That is a political and legal societal institution that really weighs on people with intellectual and developmental disability. So that also goes into stigma and ableism, and also other intersectional fundamental determinants like racism and homophobia. Then in a level below, we have social status, where those determinants of health can impart and impact someone's socioeconomic status, reducing educational attainment, employment opportunity, and health insurance availability. And this factors in with race and functional ability and all of these societal status issues that could impart difficulty for one to get the care they need. Leading to mechanisms, which is our third rectangle. Often we see more depression and anxiety, preventable medical conditions unrelated to the phenotype of the disability that cause impairment. Specifically in that area, we also get to medication use, which can have direct impacts on pregnancy. Many epilepsy drugs can cause pregnancy-related complications. We're going to focus on the lack of appropriate prenatal care today, but there's also a lot of lifestyle mechanisms that could cause poor outcomes. And then our outcomes that we know are more common in disabled individuals. This is our last rectangle: infertility, pregnancy loss, preterm birth, gestational diabetes, and so on. So as Dr. Mitra mentioned, my work mainly focuses on intellectual and developmental disability. So we have a scoping review under review, looking at the state of the literature of prenatal care for women with IDD, intellectual and developmental disability. Since 2000, we've identified 17 studies looking at this topic. And sort of the takeaways that we have are that a high percentage of women with IDD receive prenatal care, which is great, but uptake is significantly lower and received later than women without intellectual and developmental disabilities. So for instance, in our work in Wisconsin Medicaid, women with IDD, upwards of 95% are getting prenatal care at any point during pregnancy, but that's still 2 or 3 percentage points lower than women without IDD. And that disparity still exists. It's good that 95% are getting care, but they're getting it later and they're still not getting that equitable amount of care. While less likely to have regular prenatal visits, women with intellectual and developmental disabilities were more likely to have emergency department visits during pregnancy compared to peers. So this gets at adequate care. We want our pregnancy-related care to be with a regular obstetrician or gynecologist in a normal setting, and not through the emergency nature of emergency visit. And we're seeing that these women with intellectual and developmental disabilities are more likely to get that suboptimal emergency care. And as we discussed a lot on Monday, for people with physical disabilities, specific adaptations may be needed to ensure women with IDD receive adequate care, as many reported a lack of satisfaction with current care. And potential approaches could be care facilitators and coordinators, more specific literature designed for this population, help with transportation. There are many avenues which we need to pursue to find appropriate adaptations. When we talk about other disabilities, I think that Dr. Al-Hussein and Pankow made a good point yesterday about sort of the merging disabilities by type versus keeping them together versus any disability. And we'll talk more about that in the discussion. But we see that there's a delayed initiation of prenatal care for those with vision impairment, while there was no delay for those with physical disability, both compared to non-disabled peers. Women with physical disabilities compared with those without disabilities had increased odds of intensive prenatal care and decreased odds of no prenatal care versus adequate care. And women with sensory disabilities had increased odds of intensive, inadequate, and no prenatal care. So we're seeing heterogeneity by these large disability subcategories. We're seeing that there are these differences, but we probably need to be more specific by not just these broad categories, but by specific disability. And then, as we've talked about a lot through this workshop, qualitative studies find physical barriers for disabled people, pregnant people. So like a lack of care is likely a cause of poor neonatal outcomes. This is an infographic from our work in Wisconsin. There's a silhouette of a pregnant woman, and it says from 2007 to 2016, 1,032 women with IDD gave birth to 1,757 infants. That was our study population. 7% developed gestational diabetes, 15% delivered preterm, 6% developed gestational hypertension, and 26% had a cesarean delivery, all of which were higher than their peers in Medicaid without IDD. And there's been some great work by Dr. Leslie Tassaroff and Dr. Brown and her group meta-analyzing these studies. So taking all of the studies done in this area and sort of taking all the numbers together. So this is called a forest plot, and it's got the name of the study and then the estimate. And we see that across any disability, pregnant people with disability have increased odds of hypertensive disorders, with sort of a higher effect for those with sensory disabilities, but more variance, and a significant effect for those with intellectual and developmental disabilities. So what it comes down to, prenatal care is an equity issue. These disparities for disabled pregnant people remain even after accounting for socioeconomic status. We see that in our Medicaid data, where the base population is low income because it serves a criteria for gaining entry to Medicaid as being low income, and disabled pregnant people still have worse outcomes. We see racial disparity in prenatal care. This is outside of disability, but in the US, by racial group, 80.7% of white women initiate prenatal care in the first trimester, compared to 64.5% among Black women and 70.9% among Hispanic women. So there's a huge area of intersection for race and disability during pregnancy, but little is known about prenatal care. So this is some work we did to explore that, specifically looking at disparity between white and Black women with and without IDD. So we did sort of an interaction analysis where we compared white women with and without IDD, Black women with and without IDD, white women with IDD to Black women without IDD, to see if being Black and having IDD imparted more risk than we would see comparing white women to Black women, or women with IDD to women without IDD. And when we look at prenatal care, we see similar rates of first trimester prenatal care for white women with and without IDD, and Black women with and without IDD, which points to us that the driving factor here is a racial disparity. IDD did not move the needle on the differences in these rates. When we look at cesarean delivery, we see very little difference between white and Black women with IDD and white and Black women without IDD, but the difference being comparing the IDD group to the no IDD group. So there we can say maybe the IDD is driving the disparity. But when we get to gestational hypertension, we see no difference comparing the two white groups, but Black women with IDD had a greater risk of gestational hypertension than Black women without IDD. So there might be an interactive effect where being Black and having IDD leads to worse outcomes than either of those factors alone. So sort of a double disparity that is compounding. And this is seen in some minimal other research. This is work by Dr. Mitra's group and Dr. Ilhom Aghoporishev. Black women with IDD had longer hospital stays after birth compared to women without IDD, and white women with IDD. So that same sort of interactive model, seeing compounding disparity. I'll briefly touch on some methodological challenges. We're going to discuss these more in the panel session. Creating a study sample as an epidemiologist is a really important part of getting an unbiased result. We do a lot of work in claims that often lack meaningful disability descriptors. and may overlook invisible disabilities. Clinical samples or self-selected studies may not represent the broader disability population. For example, not all can afford the time and effort it takes to participate in research. It's been mentioned a few times in the panel, but the workshop this week, sample size can be an issue. We need a big data set to capture a meaningful number of disabled people for statistical power. Subsampling that for race or gender analyses gets us into issues with statistical power. And then there's a lot of heterogeneity across disabilities. Where do we lump disabilities together? Where do we look at individual disabilities? Misclassification is an area that's a challenge. How do we define disability? It's based on our research question, and the misclassification can act in a number of ways. Are we determining disability based on one's identity or by functional limitation? I think someone yesterday mentioned that 18% of people with disabilities don't identify as having a disability. What group do they go in our research? And that adds sort of finding invisible disability in administrative data and the general stigma that comes along with reporting these conditions. And then confounding is a big one. There's a high correlation between disability and being low income. And if we want to have really good targeted interventions, we may need to parse that effect out. I'm going to skip over gaps. We're going to talk about that as a panel session, as well as suggestions for future steps. So thank you. I look forward to answering questions. My contact information is on this slide, and this is a picture of my office. And I look forward to the rest of the session today. Thank you.
Thanks, Eric. And I think we're going to move on to Dr. Brown's presentation.
Wonderful. Thank you very much, Eric, and thank you for the introduction. Monica, it's a pleasure to be here. So my name is Hillary Brown. I'm a white woman with shoulder-length brown hair. I'm wearing a green blazer, black top, and sitting in front of a rather boring white wall. So let me just share my screen. Great. So Eric did a great overview of prenatal related outcomes and care outcomes among individuals with disabilities. I'm going to follow up looking specifically at postpartum outcomes and care experiences. I have no conflicts of interest to disclose, but I'll just acknowledge funding from NICHD for some of my own work that I'll be talking about today. So by way of background, why focus on the postpartum period specifically? Well, we know that the postpartum period is a time of significant physiological and psychological change for new mothers. Not only are individuals recovering from childbirth, but they're also adjusting to the stressors of parenthood and dealing with stressors related to fatigue, infant crying, and potentially breastfeeding and chest feeding challenges. And yet, postpartum care is quite different than what we see related to prenatal care that Eric mapped out so nicely. In the postpartum period, individuals who have just given birth typically only receive one routine postpartum visit at around 4 to 6 weeks postpartum. And the focus of care really shifts from the parent to the baby in the postpartum period. And so the postpartum period is a time of particular vulnerability for all new parents and potentially especially for those with disabilities. So in the few minutes that I have today, I'm going to talk to you about existing literature on routine postpartum healthcare access in people with disabilities, the occurrence of physical and mental health complications in the postpartum period, as well as postpartum acute care use. And I'm also going to draw in some of qualitative research from our team looking at postpartum healthcare experiences. We heard some really impactful and powerful stories on Monday, and I think these quotes sort of extend that and show some of the experiences from a broad population that's existing in the literature as well. I'll do my best to try to summarize the existing literature from multiple different research teams, and I'll use some examples from my own research to illustrate. So starting with routine postpartum healthcare access, there's actually very little research looking at access to postpartum healthcare compared to the body of research that there is on prenatal care. There's really only a handful of studies using population-based data, and those that do exist are mostly focused on women with intellectual and developmental disabilities. Research from the US suggests, in fact, that there are little differences in terms of routine access to that 4 to 6 week postpartum healthcare visit among individuals with and without intellectual and developmental disabilities. However, there is a much higher use of mental health care services, ancillary services, home health services, as well as visits to healthcare providers for issues such as alcohol and drug use. And so even though we're not seeing an overall difference in terms of routine postpartum care, there is a suggestion that there's a need that's being shuffled to these other types of healthcare services. So what do we see in terms of physical and mental health outcomes in the postpartum period? Again, there really isn't as much focus on the postpartum period as there has been for pregnancy-related outcomes. But the existing literature does suggest that individuals with disabilities are at elevated risk for a range of complications in the postpartum period, including severe maternal morbidity, which is a sort of composite indicator of what you might call life-threatening complications or extremely serious complications that have a real impact on the individual, both in terms of long-term impacts on that person's well-being, but also in terms of potentially long separations of new parents and their infants at a time that's really important for bonding as well as breastfeeding. So we've done some work in this area in my own research group, and I have a figure on this slide here showing risks of severe maternal morbidity across pregnancy, the early postpartum period, so the first 6 weeks, as well as the extended postpartum period from 43 to 365 days postpartum. And I'll focus on the postpartum data. And what's really notable is that what we observe is that there's elevated risk for severe maternal morbidity among individuals with physical, sensory, intellectual, and developmental, as well as multiple disabilities in the postpartum period. And not only is that risk elevated in the first 6 weeks postpartum when people are still being followed by a healthcare provider, but it also extends beyond 6 weeks when that postpartum care usually ends. And the risk does extend across the full year postpartum, suggesting that there's a real opportunity to support people better across the extended postpartum period. There's also some research looking at mental health in the postpartum period specifically. Supporting new parents is extremely important to support well-being as well as to support the parent-infant relationship. And so mental health is a really important component of that. And there are a handful of studies suggesting that individuals with disabilities are at increased risk for postpartum depression. In our own research, again, we've been able to look at this across the extended postpartum period, so that full year postpartum. And what we see is that there's elevated risk of postpartum mental illness in individuals with physical, sensory, intellectual, and developmental, as well as multiple disabilities, both in individuals with a history of mental illness, which suggests that the postpartum period may be a time of potential relapse for individuals. But we also see that elevated risk in individuals who have absolutely no history of mental illness prior to pregnancy, which again suggests that the postpartum period is a time of particular risk for new onset mental illness and a time where we could be doing a lot more to support new parents. We were also able to break these data down, and we see that there's elevated risk across different types of mental illness, including general mood and anxiety disorders, but also for more serious outcomes such as psychotic disorders and substance use as well. So lots of opportunity to provide better support. I'll briefly touch on postpartum acute care use as well. These are important indicators that tell us, if individuals aren't getting the support that they should be receiving in outpatient settings, where are they ending up in the healthcare system? And what we really do see is that there's higher use of acute care, again, suggesting gaps in routine care for individuals with disabilities. So looking first at emergency department visits, there's research from multiple healthcare systems, including Canada, the United States, and elsewhere that suggests that people with disabilities have higher rates of emergency department visits, both in the immediate postpartum period as well as long-term. So again, with the work that my team has done, we were able to show higher rates of both medical as well as psychiatric emergency department visits, again, within that first 6 weeks postpartum, but also across the extended postpartum period, with particularly elevated risks for individuals with intellectual and developmental disabilities. Similar patterns for postpartum hospital admissions. Fortunately, these are rare. Only about 4% of the population will experience a hospitalization in the postpartum period, regardless of disability status. But again, we see important disparities between individuals with and without disabilities. Again, there's data from multiple healthcare systems suggesting this, and in the research from my team, similar patterns as with emergency department visits, with elevated rates of hospitalizations for both medical and psychiatric reasons in the first 6 weeks postpartum, as well as beyond that in the extended postpartum period, up to 1 year postpartum. So I think what these population-based data do is they provide us a good understanding of disparities that we're seeing at an overall level, and they provide us clues about areas where we could be providing better support. As I mentioned, this series of workshops has been fantastic in terms of hearing from different groups, and we heard from mothers on Monday's presentation who shared some really important experiences. And I'll just try to extend some of that conversation by commenting on some of the qualitative research that exists regarding postpartum care as well. Again, I'll reference overall research, and I'll draw on some work that my postdoctoral fellow Leslie Terzov has led, interviewing people with physical, sensory, and intellectual and developmental disabilities in Ontario, where we are. So regarding postpartum care in terms of focus on mothers, one of the most strongest sort of messages that we hear from mothers is that there's a real drop off in care in the postpartum period compared to during pregnancy. People feel like they're just sort of let go after their baby is born. And so as an example here, what we see here is a quote from one mother that said, there are just no resources. I had the baby and we're done with you. So quoting sort of her perception of her healthcare providers. When you're high risk, it's a double-edged sword. When, okay, great, you have the obstetrician looking after you, but after you deliver the baby, you're done, nothing happens. If I'm high risk, wouldn't it still be high risk 6 weeks after the postpartum? So again, this perception of perhaps more intensive supports during pregnancy and a lack thereof after the baby's born. Regarding mental health specifically, a lot of parents also commented that, there's a gap overall, but the gap is especially noticeable in relation to mental health, that there was very little attention paid to their mental health in the postpartum period. And mothers also spoke about the feeling of, even if they were struggling, the feeling of needing to prove themselves, especially if there was a fear of Child Protective Services involvement. So one mother told us, as a disabled mom, I felt I had to make it seem like I was doing better than any, quote, normal mom, because I was afraid if people thought I couldn't do it, then they would assume that it was a mistake for me to have a kid. I didn't reach out to supports because I was trying to hide. That was really hard. Even if people told me, yes, it's really hard, I felt I had to still prove that I was doing okay. So, a sort of hesitation to seek out supports out of fear of being judged. There's another of other stressors that I think are important to consider that really, again, speak to the population-based data and sort of provide clues about what's going on. And one of the most common challenges that we hear about is related to breastfeeding. And there's a lot of really great literature in the qualitative literature from others on this as well. And we heard about this, especially from individuals with physical disabilities, as well as sensory disabilities, in terms of a real lack of adaptable resources, which added considerable mental health strain. So one mother who's blind commented, when you're in the hospital and they're teaching you how to breastfeed, they do this thing where they hold the baby, they wait until the baby's mouth is open, and then they fly it on when they think it's the right moment. But that doesn't teach the blind person how to breastfeed at all. That makes the blind person totally dependent on having the nurse there to watch when the baby's mouth is open. So again, sort of illustrating how resources and supports really didn't consider the long-term needs of individuals. Parents also talked about inaccessible newborn spaces, which again really sort of contributed to stress in the postpartum period. So one mother with a physical disability said, I was asking them, her provider, her pregnancy related provider, I don't know what pediatrician to go to because I was afraid of being sent to one that was not disability affirming. And it would either be inaccessible for me to attend her appointments, or they'd have a lot of questions about me and how we took care of the baby. But they don't have those resources yet. Either nobody knows or they, her providers, just don't know. I had to talk to other people with disabilities about the places that they would go. So again, some gaps in terms of providing good care to the mother-baby unit. And then finally, one of the strongest stressors, especially for those with intellectual and developmental disabilities, was fear of Child Protective Services involvement. So one mom with IDD commented, it took me to get the parenting program worker and the adult protective service worker, which is a term used for developmental disability service worker, and every other support involved in order to get my child home. I had Child Protective Services involvement from my previous kid. I didn't feel very open about having all these people come and be involved in my life because I thought everybody would be against me instead of trying to help me. So I hope that sort of gives you a sense from the literature of, both the overall disparities as well as some of the experiences that, contribute to stressors in the postpartum period. We'll talk more about clinical implications in our panel discussion, but I just want to briefly summarize that, what we're really seeing is that even though individuals with disabilities may be able to access that routine postpartum care visit at 4 to 6 weeks, there are still significant disparities in physical and mental health, as well as, gaps in care that result in the need for acute care utilization. So lots of work to be done to provide better support. Such support could be provided better by, setting up plans during pregnancy, anticipatory guidance to develop postpartum plans, as well as a team of formal and informal supports that can be there for new parents once those obstetric supports sort of fall away. Our data really suggests a need for enhanced follow-up early in the postpartum period, but also ongoing care beyond that standard 6-week postpartum period, recognizing that people's situations don't, magically resolve at 6 weeks, and that often new parents need support well beyond that period, full to the full year postpartum. So I'll end it there and stop sharing my screen. And I think we will start our panel.
Yes, thank you, Hillary and Eric, really for your insightful and really thoughtful presentations. We're going to spend the next 10-15 minutes just as conversing and talking about the gaps and the next steps in the research. So, and then we're going to open it up to the larger community of attendees. So I'm going to start off with a question, and I think both you and both of you sort of ended your presentations with that, but really thinking of what are the major gaps in the research in pregnancy and disability. And I'm really particularly interested in something that Eric raised at the end of his talk, but is in the gap in research on disabled people of color.
Yeah. So I think it's a really good point. And we should be thinking about both gaps and sort of how to fill those gaps. And, I can talk from firsthand experience using Medicaid data in Wisconsin. We tried to look at some racism related double disparities, but in a state like Wisconsin, the population of Black pregnant women with developmental disability was not large enough to support our hypotheses and our statistical testing. So it's a challenge from sort of a quantitative methodological piece. I think that that's where qualitative work can really step in first, make the inroads in the community, build support, build trust, and then start thinking about small cohort studies, targeting is a strong word, but trying to recruit people of color and really sort of making a focus of building cohorts that way.
Yeah, and just to briefly add to that, I agree there's definitely a need to study, groups that are multiply marginalized, so that experience multiple risk factors. I think the experiences of racism is a really great example. And Eric also touched on issues related to gender identity and other populations that might experience discrimination from healthcare systems for different reasons. So sort of thinking about the intersection of disability and the social determinants of health from multiple different angles, I think is really critical. I would just also briefly add that I think in addition to, we have this body of literature on disparities, and we have this parallel body of literature from qualitative research on barriers to healthcare. But from a quantitative perspective, we really haven't connected the two together. We talk about them in parallel, but I think there's also a need for research to connect those and to really understand what is driving those population level disparities. I think, Eric, it sounds like some of the work you're doing is trying to start to do that, looking at some of those pathways, but I would love to see more work really sort of looking at what are the social and other factors that are really resulting in these population level disparities that we're seeing.
Yeah, and I can talk about sort of I think a big angle for research is policy. And I think that, so Dr. Brown, you're in Canada, we're in the US, it's really specific to the country you're in, the state you're in, those factors are levers that we can turn to improve access for many marginalized groups at the same time. Hillary, your talk reminds me of sort of in the American Rescue Plan, they passed a waiver ability where states can expand postpartum Medicaid for up to a year, which would have huge implications for disabled people on Medicaid who may lose service, Black people on Medicaid who may be more likely to be on that borderline living in states that don't expand. It doesn't cover the full population, right? So when we're talking about Medicaid, we're talking low income. That's only a subset of the disabled population. But when we think about policy, we can really make big strides in a lot of areas at once.
Yeah, thanks, Eric, for noting the what was in the ARP, and I think that could be a game changer. Or at least a start towards it. And just and I think we as researchers, we need to be, despite the sample size issues, be cognizant of the needs of multiply marginalized people. And as Heather Watkins pointed out, is that we need to improve our understanding of the range, nuance, and the complexity of disability while being mindful of the overlapping identities. And I thought that was really powerful. Related to that, and I think this is something that we as disability and health researchers can really relate to, is how do we address these commonalities and the differences given the unique needs of people with different types of disabilities, as we're building this body of research on pregnancy and disability. And I think whether it's from a programmatic perspective, but especially on a research perspective, is how do we determine sort of when uniform approaches are needed and when separate approaches are needed. And I know there's no perfect answer to this, but I would love to hear your thoughts.
Yeah, I think it's a great and challenging question. I think from a health systems, policy and planning perspective, the commonalities are really important, because from a health systems planner's perspective, it's a good sell, right? To be able to say that there are certain things we can do that will meet the needs of multiple people. And from the work that we've done, what we really hear over and over again is a need for more flexible perinatal care structures. So the option to have longer appointments when they're needed, the option to have more appointments when they're needed, the option to have remote appointments, which maybe COVID, has opened some doors there in terms of the option for, virtual visits for people who have difficulties with transportation. And so I think a good sort of common way of thinking about this is the changes that can be made to the healthcare system that can accommodate different types of needs, and the reimbursement policies that need to go along with that. Likewise, other pieces relate to better coordination of healthcare, allied healthcare, and social services. That's a common need that we think about. But certainly there are also specific accommodation needs related to, mobility and communication needs that will be different across different disability groups. But I think those health system level pieces are a nice way to start that kind of speak to multiple ways of being flexible.
Yeah, and to add to that, I like sort of thinking in the mapping out a conceptual model and really determining whether you're gonna, what disability group or all of disability as a whole you're gonna look at through specifying your research question. If we're interested in the effects of ableism on preterm birth, we should include all disabilities because they all experience ableism. Maybe we do some sub-analyses to look at specific different types depending on disability, but it matters for everyone. If we're looking at something like medication use among disabled people, there might be really big differences between disability types. I mentioned epileptic drugs and causing pregnancy complications. That is a high concern for people with intellectual disabilities. It may not be for people with physical disabilities. So by knowing our question and being very clear, we can sort of help decide and drive whether we want to do a broad analysis of all disabilities or be really more specific on certain subtypes. And I think it's important to sort of be aware of that, because you can find, as I talked about with sort of access to care, sometimes things are going in opposite directions where one disabled group is getting too much care and one's getting too little care. And if you merge them together, it's going to look like they're getting the appropriate amount of care and you're missing problems on both ends.
Right, and I think that points to the research that you presented on prenatal care, right? Because sometimes there are no differences by disability, but you're not taking into account the quality of the care and the experiences of people. So I want to also kind of pivot to, Eric, you used the phrase knowing your population, and I just want to talk about inclusive research. So how can we ensure that our research process from study design to dissemination is inclusive? It incorporates the voices of people with disabilities. And really critical to this is how do we move from developing research that's on behalf of people with disabilities to research with and research by disabled people?
For sure. I mean, sorry, Eric, I see you unmuting yourself as well. I can just provide a brief example of some of the things that we've tried to do. And I think underlying all of it is the need for meaningful engagement and not sort of, tokenistic involvement, but really allowing people to be involved in ways that make a big impact and that help to determine the direction of the research questions as well as the interpretation of the research questions. I think having an advisory committee of people with disabilities is a really great start to get input at key stages of the research process, but that can still sometimes be sort of arm's length and somewhat removed. And so, also having what we call peer researchers in some of our work, we've had research assistants who identify as disabled, who do the actual data collection and who work alongside students and that sort of thing to do the research and are involved in manuscript writing and presentations and that sort of thing as well. And that's been a really wonderful experience, I think, on all sides. And I think is, an example of one way to really make sure that groups are meaningfully engaged.
Yeah, and I can sort of speak to some of the barriers that are kind of inherent in the academic system. I mean, not all research is done in academia, so I can only speak from my experience there. But one thing to note is, I'm a relatively new member of a faculty, and as a student during my training, there were no resources to compensate adequately members of a community advisory board or co-researchers. It was not an option for me because I would have to pay out of pocket. There was no support from my institution, which makes it hard for the next generation of researchers who want to pursue this work equitably, who may not have a mentor that's as familiar with these tools and the importance of this. Their hands are kind of, or that they're kind of stuck. They really can't push forward because without the money, without the support. And then that also goes to, as we talked about yesterday, about hiring disabled clinicians, more disabled students, training in research, disabled principal investigators, disabled leaders in scientific fields. That will definitely promote inclusion and sort of having the research be led by those that know the field and their lives the best. And then the last thing I had, I lost it. So talking about postpartum care, I have a 10-week-old, so things are very quickly leaving my mind these days. So if it comes back, I'll fill in the blank.
No worries, Eric. Been there, done that. So I really appreciate, Eric, what you brought up is in terms of that next generation of researchers. And I really feel like it is our responsibility in how we train the next generation and ensuring that we are mentoring, students and the next generation, junior investigators with disabilities intentionally and thoughtfully. And I think that that's sort of, key to conducting inclusive research. I have one last question before I hand the virtual mic over to Dr. Riekert is, again, we're all sort of disparities researchers and we focus on sort of disparities, right? And so how can we move this conversation, move past the conversation on disparities and into actual strategies for action? And really what policies and practices are needed to both address these disparities in perinatal health, but how can we collectively develop this body of evidence to support the perinatal needs of people with disabilities?
So I can go first this time, and something that's kind of frustrated me about being in this research world is just how overwhelmingly negative and scary all of this is. And we always talk about poor outcomes and barriers and disparities, and they exist. They very clearly exist, and they very definitely need to be addressed. But there still is a lot of great stuff being done and huge amounts of success that we need to research. We can write papers on what works, and doing that, we can then sort of develop more interventions. We really know what doesn't work, and it's important to characterize that. But I think at this point, it's kind of, I think we're ready to shift towards the positive and really start thinking about pursuing success rather than preventing negatives. So yeah, I think we should, and that I think will reduce some of the stigma, because when we just consistently talk about how poor outcomes are, it can sort of, in a way, lead to more stigma with saying, oh, do you know how bad outcomes are for this population? And well, it's because of structural disparities and all of those things, but not everyone is up to speed on that conversation. So I would say we can start promoting the positive and doing more research about what works.
That's a really nice way of putting it. And I think that's something that we hear from our advisory committee with my research group is, don't focus on the negative, don't medicalize this more than it needs to be, and I think one of the ways that we can address that is when we're presenting these findings to also talk about how rare some of these outcomes are. 95% of people with or without a disability will not experience any complications during pregnancy. And yes, those disparities exist, but there is a spectrum of, really good outcomes that most people experience. So I think that's part of it. I think another part of it too is developing supports and testing those supports and moving research from disparities research to, quote, intervention or support-based research. And I think that's what's so exciting about, the Center on Pregnancy and Disability funded by NIDLR that, Monica, you're leading along with Lily Horner Johnson, that, that center is really focused on identifying supports and testing their effectiveness and satisfaction in the population. So, it's remarkable how consistent findings have been in this research from the US and Canada, for example, with two very different healthcare systems. I think we know in some ways what we need to know about disparities to move on and now try to address them. So lots of, positive outcome focused work that can be done now.
So I thank you, Hillary, thank you, Eric, and I really appreciate sort of moving in a positive direction. And I really wanted to quote what Jennifer Sender said on Monday, is that we need to take the box, we need to break it, we need to shatter the box. So I feel like we're collectively doing this. And on that note, Dr. Riekert, I'm going to hand this virtual mic over to you.
Thank you, Monica, and thank you, Eric and Hillary, for your really impressive work. It's informative and it's powerful, and I'm so grateful that you guys are doing this research and that you're here today to share it with us. And as you said, Hillary, I think, you know, you were commenting about the overarching themes internationally, but we also saw such overarching themes across all 3 days with the moms with disabilities, the healthcare providers, and with the research. And so I think that is a step in the positive direction, showing that, you know, we're all already on the same page in a lot of ways. And so we can take advantage of that momentum and move forward with it. So now I'd like to turn to some questions from the audience, the virtual audience. I've received a couple of them, but please go ahead and send me more questions as you have them. Maurice Davis asked, can you comment on paternal involvement or the lack thereof in prenatal and postpartum care and maternal care in general for pregnant women with disabilities? And I would expand that out to just partners in general, and including partners with disabilities themselves that may not be addressed in any of the realms, so that they can better support their spouse.
Yeah, it's a really good question. I know that in the data I work with, we aren't able to link dads into the story, which is really one of those gaps and limitations that prevents us for sort of getting the bigger picture. I think Maurice makes like a really good point that is super important. And there's often, you know, both parents have disabilities. And I think maybe it was mentioned Tuesday about sort of the ASL interpreter getting taken with the dad to the NICU, and then the mom is left without the interpreter. It's huge issues. And Hillary, I don't know if you have that linkage between mom and dad in your data, but it would be interesting to have that resource.
Yeah, it really is a limitation of the population-based data that we use, that often you don't know who the father is in your data. We're working on ways of sort of approximating that based on where people live and that sort of thing, but obviously that's imperfect. But certainly from qualitative research, there's data there to suggest some of the disparities that were just mentioned, or the barriers that were just mentioned, for sure. A good area for research.
Yeah. We have done some research on fathers with disabilities using the National Survey of Family Growth, and what we're finding is, and you know, at the expense of being negative, is that disabled fathers are also more likely to have poor health outcomes related to both physical and mental health. And we've also looked at birth intendedness among fathers with disabilities and found sort of similar disparities as mothers with disabilities. In some of our qualitative work, and again, I think I completely agree with you, Hillary and Eric, it's hard to, you know, in our also administrative data, it's hard to link both parents, but what we found, a couple of things is, for example, with women with intellectual disabilities, there was definitely disparities in paternity establishment, which has long-term consequences for both the mother and the child. And by paternity establishment, is really referred to when the father or the other partner his name is not included in the birth certificate. And this raises some really challenging, sort of interesting questions. And again, this was more so for younger women with intellectual disabilities. So more questions than answers, but definitely, and I completely agree with Maurice, that this is an area that we really need to focus in on.
And to add to that, and maybe answering some other questions, is that I kind of feel that starting at conception, we're already starting too late when it comes to research. You know, when we had the workshop last week on reproductive and sexual health during transition age, we really didn't talk much about pregnancy, which makes sense because in a typical life course, that's a little later, but it's the same people that are going through transition and sexual reproductive education that are getting pregnant. And we tend to think of them as two different populations. But if we sort of started researching and following those men and women, boys and girls, then we might have a better source of data as we're following everyone before we're getting to that incident moment of pregnancy.
And this is so interesting because I think the life course perspective is so important, and also that's one of the things I really appreciated having the NICHD workshop last week, and then followed by this set of workshops, and I think we really need to sort of, just as it is with women and mothers of color, is this concept of cumulative burden, and we really need to also look at that as sort of this lifetime of ableism and stigma and discrimination that people with disabilities face. How does that impact a person, or the maternal and birth outcomes, and again with paternal outcomes as well.
Excellent points. Thank you. We have a question from our panelist yesterday, Jeannie Al Houston, and she says, "Thank you for a wonderful presentation." She wants to know if any of the panelists are aware of any research on different models of perinatal care delivery, such as group-based perinatal care, which has shown to have beneficial effects for certain populations, including women of color.
Well, so specifically in intellectual developmental disability, we didn't find anything in our scoping review. It's a great idea. I would imagine that maybe if you were in a big city, you could find the group, enough of a group to do it for intellectual developmental disabilities. But for other disabilities, I think it would make a lot of sense, and I'd be interested to know if there was strong evidence base for better outcomes there.
I am not aware of any either. There is one project that we're working on with Dr. Kara Ayers, but it's not really prenatal delivery or perinatal delivery, but this is part of that new NIDLA funded center. But we're really examining on birth plan, inclusive birth plans for women and people with different types of disabilities. So more to come. Hopefully in the next couple of years, we'll have something important and positive to report.
Great. We have a question from Yen Baines, who asks about participatory action research methodologies that would include and sustain participation from people most impacted to drive the research. And he wants to know, have there been participatory action research or PAR efforts in this research? And if not, why not? And if so, where might we find information about those efforts?
I think there's sort of a variety of sort of efforts along that spectrum. I'd be interested in hearing from others sort of, if they know of research from a participatory action research perspective. Specifically in the qualitative research that we do, I would say it's definitely community-based. We try to drive the research questions based on questions that our advisory committee brings to us. We have researchers who have disabilities doing the interviews. But I know that there's, again, sort of a spectrum in terms of how we define that approach to research. And I think ours probably falls somewhere in the middle, but certainly the involvement of and direction by people with disabilities is extremely important for this type of research.
I can go next, and it's a really important question. And for the new NIDLA funded Center on Pregnancy and Disability, this is something that we really we're really making efforts to ensure that our research is inclusive, and we're following PAR methods. So many of our investigators and project directors are disabled researchers. In addition, we have a very strong and active advisory board committee that we will be, that'll be guiding our research throughout. And the third piece of it is we also have peer researchers. So who are community members who are going to be, including, actually, I think you met one of them, Heather Watkins, on Monday, and we will be training and who will be conducting some of our research studies. So it is a blend, and we're really, trying to be very intentional and thoughtful about this.
Excellent. And that is certainly a big focus that NIDLR has in all of our funding mechanisms to involve stakeholders in the research. And there are quite a few examples we could turn to with that. And so if you wanted to contact me directly, I could connect you to those specifically, Yin.
Amanda, I just want to add to that is that
Sure.
what I really appreciate about sort of the NIDLR mechanism is that PR is not an option.
Mm-hmm. It's
and
in
it
the
is
funding,
built
it's
in and
required.
baked into the way. And I think that makes a huge difference for disability researchers and for all researchers, but I'm just saying specifically disability researchers, because that is the way, we want to follow the disability rights mantra on nothing about us without us, and having it baked into the FOA makes a big difference. Because we can weave it in so many different ways. But just what Eric was mentioning is when you don't have sort of the ability to pay stipends, when you don't have the ability, when it's not part of the culture, then it becomes very difficult and it becomes forced and superimposed. So I really want to commend NIDLR on this.
Thank you. Yeah, I agree. Linda Long-Galil asks, have any of you considered developing an intervention in coordination with maternal and child health programs, for example, home visiting programs postpartum or during pregnancy?
I haven't, but that's a great idea.
I think it's a fabulous idea, Linda, and I think particularly actually involving HRSA, because HRSA funds a lot of training programs, and throughout, whether it's day 1, day 2, day 3, as well as in the NICHD webinar last week, it was, there is this gap need for training healthcare providers and allied professionals. So I think that that's something that we really need to we need to as researchers and is really find ways to pilot these training programs and fund them.
And just to add quickly to that, we've done a little bit of work creating resources for healthcare providers. And we have a resource that should be coming out this month for public health nurses that basically provides information on disability and accommodation needs during pregnancy, as well as tips from moms with disabilities about how to work with them in the perinatal period. So we've done some work on that. And I'll just also mention there's a researcher in Toronto where I am, Amanda Kappen, who trains developmental service workers, who's developing a program to train people who work in social work and child protective services on how to provide better support to parents with disabilities during the perinatal period. So I believe that project's just started, but there's definitely some ongoing work that I think will be really promising in the next couple of years.
Well, we
So
definitely
Hillary,
look forward to that. Oh, go ahead, Monica.
Yeah, no, me too. I think that's a really that's going to be a great resource, Hillary. I also wanted to add, and just going back to Linda's question, because I also know she's written a book chapter on this issue, is this really need for the Maternal and Child Health Bureau and those practitioners, for example, in the Departments of Public Health. I'm going to just be US centric here, but is really to include. They do a very good job in including kids with disabilities through their special health care needs programs, but these children become adults, and I think it's really important to also focus on their reproductive health needs, on their perinatal health needs. And I think so that is a really critical area of research, practice, and policy that we need to focus on.
I think this question and the answers that you've given have really emphasized a couple of themes that have come up across all 3 days too. And one, of course, is education of adolescents and women with disabilities, education of healthcare providers, clinicians, existing clinicians, and training, new med students, new students in every practice. And then the other theme that's come across, and that I think this highlights, is really the important role that allied health services play. And, especially in breastfeeding, as you mentioned, Hillary, it's come up a couple of times. But it's come up in a number of ways. And it's something that it's often, the research seems to focus on obstetric care, especially from an obstetrician, truly an MD. But really, that's such a small piece of the interaction. And there are so many other supports and services that are needed in the community to help parents succeed ultimately, and to have positive pregnancy outcomes and healthy pregnancies. So I think that really has come across a lot over the past 3 days.
And Amanda, if I may, I just want to add to is, training education is vital, but we also need to ensure that the facilities and the programs are accessible. I mean, the horror stories that we've heard in the last, in many of the qualitative studies I've done, and it is shocking. And you would, 31 years past the ADA, and we're still women with disabilities are still not being weighed. I mean, some of them have been turned where they're expecting their spouses to carry them, and while they're being weighed, or sending them to different parts or different different areas, or the clinicians just saying, I'm going to just visually guess your weight. And this is really shocking, and just one indicator of the lack of accessibility. So I think we really need to focus, on accessible spaces, include in addition to training.
Yeah, I think that's a really powerful component to bring up, and a good example of the inequities, because I think what I've read most recently, about 4% of obstetric offices have accessible scales. And that's a primary component of prenatal care. So it's unacceptable that is completely ignored for so many women with disabilities. One more question we have. Ami Young says, it was somewhat touched upon, but I feel there's a need to be lifting up of this. The focus of this is heavily on the medical system side, which I feel is a bias that really needs to be examined. Granted, I'm a sociologist, so I'm biased to look at social system issues with the medical system as just a subcomponent of the issue. If the disabled parents can't trust that the safety of their family, if they seek professional support, they're not going to seek the support. It's a really powerful statement. Anybody want to respond to that?
Yeah, I think that's really powerful, and that speaks to a lot of what we hear when we talk to mothers. And I think it really speaks to the ongoing, pervasive negative societal attitudes toward disability and sexuality in particular. And we can try to educate providers all we want, but if we don't tackle that attitudinal piece and sort of the broader societal issues, it will only do so much good. So I'm not sure I have a good answer for it necessarily, but I do acknowledge, that we need to be doing a lot more at sort of a societal level in terms of inclusiveness and diversity, and really acceptance of diverse populations who experience pregnancy.
And from sort of a analytical research quantification point of view, we kind of know how to quantify the healthcare system and medical situations, whereas our measures of racism and ableism and interactions with other social systems that may not have as strong data structures. We don't have those tools, and we need to make those tools. That's sort of on us as researchers, is to develop analytic tools to quantify some of these issues that let us do the advanced causal modeling that helps us find interventions. We're sort of behind the curve when it comes to non-medical settings, just really for all of public health, but in this case particularly.
And especially, I would add to that we don't even have a great standardized way of identifying people with disabilities in the data, in any data. So that is prohibitive as well. Sorry, Monica.
No, I totally agree with you on that. But to that question, I think that on community, it is truly, truly critical and important, and we need to address that. I mean, this is where eugenics, this is where Buckley-Bell comes in. This is this sort of pervasive negative attitudes towards seeing people with disabilities as non-sexual beings, as unable to parent. And in almost every study that we've done, which is on parents with physical disabilities, deaf and hard of hearing, as well as intellectual and developmental disabilities, we have seen this fear across, that they are fearful of their children being taken away from them. And in addition, I'm also the PI of a NIDLR-funded center on the Center for the National Research Center for Parents with Disabilities. And through that, we've been looking at the attitudes of child welfare professionals and in the disproportionate rates of the termination of parental rights for parents with disabilities. And it is truly horrifying that at this day and age that this is actually happening. So I think that there is these needs, for example, of training child welfare professionals, that you cannot use disability the reason for removal of children. So I am, yes, I think this is a very important issue that we need to tackle and address.
Mm-hmm. And to train obstetric nurses to help put the moms more at ease. We've heard that all 3 days too, about moms feeling like they're being watched too close, or they're too closely, and they're afraid they're going to do something wrong, and somebody's going to take their kid away. Or even Monday, one of the moms reported that she was being encouraged to give her son up for adoption right at birth, and she had no intention of giving up her child for adoption, and it was inappropriate for that to be raised. The one last question, and then I can't remember. I don't remember who brought it up, but it's Jackie Wallace asks, could you repeat that again? Where should providers go to get information about caring for pregnant people with disabilities? And actually, if you could send it to me in the chat, I'll make sure that we send that out in resources when we keep the conversation going following this workshop. So
ACOG used to have a link in their website, but I have not seen that recently. That's the American Congress of Obstetrics and Gynecology. We have some resources in our National Research Center for Parents with Disabilities, and Amanda, I'm going to send that to you. You probably have a link to it, but also I think the work that Hillary's mentioned.
Yeah, great. That would be perfect. And I am mindful of the time. We have 1 minute. I just wanted to again mention what Allison Cernich told us on Monday, that NICHD recently released a NOCI on reproductive health, pregnancy, and parenting among women with disabilities. And NICHD's council approved a concept focused on promoting reproductive health for adolescents and adults with disabilities. And so there's more work, more money on the horizon for this kind of work, and that's also very exciting and gives us more hope. As I mentioned, we will be writing a summary report of some sort following this workshop, and we'll share that with you down the road as it is completed. And we will also make the videos available of all 3 days, so that you can watch it again or share it with other people. And we will, the report will include, or some emails will include, those resources that have come up over the 3 days that are known to be particularly strong. And I just want to thank everybody once again. This was a great session. It went so fast. I think we definitely need to do this again. And I appreciate your time and your expertise and sharing it all with us today. So thank you very much. And I'll turn it over to Sadie.
Thank you.
Great, thank you, Amanda. And thank you all for attending day 3 of the Accessibility of Motherhood, a workshop on disability and pregnancy. This concludes today's event and this workshop series. You may now log off at any time.